all get aches and pains in various places. So I asked Dr. Steinberg how he knows when the pain that someone gets is actually caused by osteoarthritis.
Oh, we pretty much start with the clinical, and the types of complaints patients have. A lot of patients will complain of stiffness, especially if they've been sitting for long periods of time. It's usually one of the clues of arthritis. Certainly age plays a role in that, and ultimately an x-ray will help. I mean, you put all of that together, and on x-rays you're looking for basically joint space narrowing, where you're seeing bone-on-bone contact. You can see bone spurs, or what are referred to as osteophytes on the x-ray. And then again, a lot of it's clinical. A lot of times you'll see deformities, in a leg where it's no longer straight. Patients will come in and they'll say they're bow-legged, or they're noticing their legs or their knees are becoming more knock-kneed. Those are pretty much clues. But a lot of it, again, goes back to the patient. So
the knock-kneedness is because the angles are being altered by the arthritis?
Yes, it's typically uncommon to see both sides of a knee joint to wear out at the same level. Usually one side will wear out more so than the other, unless there's been some type of trauma that's really damaged both sides of the knee.
And then that will be apparent just looking at their knee.
Definitely.
Wow. John, what can physical therapy offer someone with osteoarthritis? Like someone like David, pre-operatively, I mean, even way back when he started to get his arthritis, was there anything that could be done to help him?
Right. Well, there's a big focus in moving toward wellness at the moment, which is great. As Dr. Steinberg mentioned, obesity is a huge factor, and unfortunately I'd love to get these clients about 5 or 10 years before I actually see them, because then we could really make a big impact, because the biggest issue really is that their body is overwhelmed with the weight that is over top of their joint, and their body is caving out, and so that they can't support it, and it gives in, and then you end up with surgeries. A physical therapist works a lot on strengthening a joint. A joint that is strong and that is mobile is a healthy joint. So specifically working at that joint is important. But historically, it's not just that joint that's involved. For example, if you've got arthritis in a knee, you can't just look at the knee. You've got to look at the joint below and a joint above, because those joints will be affected also. If I got arthritis in my knee, I'm going to change how I weight bear through that whole limb. So exercises that, yes, specifically look at that knee, but then also look at the hip and look at the ankle would be important.
Thanks. Dr. Steinberg, lots of medications. Let's start with oral medications. What are some of the options that are typically used?
Probably one of the most common things is over-the-counter anti-inflammatories. Your Motrin, Advil, Aleve is very common. Tylenol arthritis is another thing. And typically when a patient comes to me with arthritis, they've usually already tried those types of medications.
So what do you step up to? I guess the anti-inflammatories plus a painkiller, or?
If you're getting to that route, there are some injections that we'll typically try after the oral medications. If patients are starting to require narcotic pain medication, you're getting into a different category where you're starting to counsel patients on surgery.
Now we see advertised on TV and things, patches or topical creams. Are they any use?
It's another one of conservative care. I don't necessarily think one is certainly better than the other. Ultimately, it comes down to the patient, and if they are improving, their quality of life is okay, I'm okay with those modalities.
And those would be just a different way of delivering anti-inflammatories, really?
Exactly.
Yeah. Okay. Now, John, if, like David, immediately pre-op, he's in a lot of pain, he's really slowing down, is it good to keep exercising? I mean, you slow down, you start putting on weight, and you start spiraling, don't you?
Right.
So what can you do to help?
Well, the research actually has been coming out pretty consistent over the last few years, that if you take somebody and you strengthen them beforehand, whether it's their particular joint or holistically their whole body, then that can accelerate their recovery. And that's what prehab is at its core.
So that's recovery after the surgery, but I'm thinking they're not facing surgery yet. Should they do exercise right after taking medications, or should they just push through that pain and do as much as they can? What's your advice to someone in that situation?
Well, in the context of prehab, so we're working with someone before they've had their surgery. What we're wanting to do is to work to strengthen that joint. Yes, it's going to be replaced. So in the sense of, can they grin and bear the pain of strengthening that joint beforehand? We hope they can. But we can specifically work on exercises that are non-weight bearing if we can. That we really kind of want to push through and work on weight bearing exercises also because they have a variety of effects that are beneficial.
Great. Dr. Steinberg, you mentioned injections. Tell us a little bit about when they're done, how they're done, what you inject.
Probably the two most common injections. The first would be some type of steroid, what we refer to as a cortisone injection. And that basically is to decrease inflammation, which I call it, it's a Band-Aid. It's not a permanent fix, but you're delivering an anti-inflammatory right where the arthritis is. And patients will usually get some short-term benefit from that. The other type of injection that's commonly used is something called viscosupplementation. I call it WD-40 for my patients typically because it's a lubricant shot. It's a gel. It's not a steroid. And there's some studies that have shown that patients can get 6+ months worth of relief with something along those lines. Again, it's not a cure and it doesn't get rid of the arthritis, but it decreases some inflammation and helps lubricate the joint. Some patients will see some improvement in function typically with that.
Can it be repeated, or is it usually for both the cortisone and that? Is it?
It can be repeated. The way it's been approved in this country is usually there's 6 months. But you know, for some patients it helps and some if it doesn't. If it doesn't give a patient relief for more than a few weeks, at least a few months would be before I would consider repeating it.
Now, John, we have the old adage, use it or lose it.
Right.
Is this true with osteoarthritis, where you've got some bone on bone, some degeneration of the joint?
Absolutely. Well, we usually are pain averse. So if you've got weight bearing through a joint which causes pain, you tend to avoid it. So if you're going to tend to avoid it, you're not going to use it. That joint is going to get weaker. That joint is going to get stiffer. Not just that joint, but the joints that are, again, are above and below are going to get weaker. We're going to change our posture. Our body mechanics of how we move is going to be compensated. So you get this spiral downhill that a lot of times not only relates to that, but then all of a sudden, if I find out that I walk 100 feet and I'm in excruciating pain, then all of a sudden my world has become very diminished. What I can and cannot do, maybe I can't go to the ball game because I can't go all the way down to the field and then back. So there's a cascade of effects that occur from osteoarthritis that can limit your quality of life.
After the break,